After, you can send me the link of the page.
يعطيكم ألف عافية. نهاركم سعيد من كلية طب الأسنان، أجمل كليات جامعة دمشق. هي الكلمة دوما بنسرقها من أستاذنا العميد الأستاذ الدكتور أسامة الجباني. بنتشكره على إمكانية هالنشاط اللي عم نساويه بشكل روتيني بجامعة دمشق باستضافتنا لمحاضرين أجانب. اليوم في عندنا محاضرة مميزة جدا بتوبك حقيقة قليل ما يتم الحديث عنه. المحاضرة هي الأستاذة الدكتورة راكل غوميز. راكل زيتا غوميز أستاذة دكتورة في جامعة بنسلفانيا، هي أستاذة زائرة في هذه الجامعة. هي حائزة على بوست جراديويت ريزيدنسي في السويد من معهد برين مارك، حائزة على الماجستير أيضا من معهد برين مارك، وحائزة على الدكتوراه من جامعة بنسلفانيا، وهي محاضرة في البرتغال. دكتور راكل, we are greeting you. We are very honored that you are lecturing in our university. Just let me introduce you in English. Dr. Rakel is invited lecturer in Pennsylvania University. She is a postgraduate implantology in Sweden Bremark Institute. She has her master degree in implantology also. She is invited as a teacher and master specializing course in oral and rehabilitation. She is living now in Portugal and she is a professor in the university. The topic today is mandibular nerve, IAN, transpassing, transposition, and lateralization. Please, Dr. Rakel, it's a great honor that you are lecturing in such a topic. It's such an advanced topic, how to manage and deal with the mandibular lower jaw nerve and how we can deal with it in implantology and surgery and extraction. Please, you can start your lecture. I am very honored to discuss the lecture with you. You can start and thank you a lot lecturing in Damascus University here in Syria, the oldest city inhabited by people. Great to you, and you can start.
Thank you so much. It's a great opportunity. My first collaboration with Syria and also with some countries in the Middle East. So I'm very happy to be here. I hope a lot of people will join. We know that we are in a difficult situation because of COVID-19, and I'm trying to do my best also to help people that can't reach or can't afford like very expensive education abroad. So I'm trying to, in these times, to stay active and to give some information via online webinars. So I will start my presentation. Let me share here my screen here. Okay, I hope you are seeing well.
I can see the presentation. Okay, just click on F5 and start full screen.
Are you seeing? Yes.
Yeah. Okay, I see everything.
Okay. So I will start. My name is Raquel, Raquel Zita Gomes, and my topic for today is how to deal with inferior alveolar nerve for implant placement. Okay, and it's a pleasure to be at Damascus University. It's my first collaboration with Syria. So where I am from, I'm from a beautiful country in Europe that has beautiful landscapes, beaches, a lot of culture, and very good wine. And it's a country that if you don't know exactly where it is, in the next slide you will know, because it's the country of Cristiano Ronaldo, the best football player in the world. I think everyone agrees. And nowadays, Portugal is European champion of football. And of course, I'm from Portugal, and I'm very, very honored to be Portuguese. And now let's start a little bit of who I am as a person, as a professional. And I'm going to show this little video for you to understand. These are my titles.
Welcome the next speaker from Portugal, Raquel.
So as you can see, I'm a very passionate wife, mother, and professional, and I love to teach. My next stop, presential stop, will be in Ukraine, I hope, if nothing will be canceled. And these are my contacts that at the end I will also share again. And I also like to start a little bit with some references, with some collaborations that I have, because I think it's important to share that I have some collaborations with universities, with the education platforms, with brands, but I always choose this in the best interest, not only for me, but for my patients. So I try to choose the best products I think they are for that specific solution. And I always try to select the best platforms and the best universities to collaborate. So this is why it's important to show this slide. And let's start in a very simple way and thinking about insufficient ridges, upper and lower, okay? And then we're going to focus on the lower jaw, that is the topic for today. But when we think about insufficient ridges, we can basically have 4 types of defects by the way it's fixed. So if I have a socket, basically I can do the decision, do I do immediate implantation, or do I do socket preservation, or do I wait? Of course, it's also an option. If I have a low ridge, basically what kind of options do I have? I have the short implants, the tilted implants to avoid the nerve or avoid the sinus, the GBR, the traditional GBR, the blocks, Curie technique, for instance, the trespass of the nerve. I'm going to explain all the differences in the next slides. And then the lateralization of the nerve and the transposition. That are 3 different concepts. They basically are with the same objective of avoiding the nerve or moving the nerve, but they have different type of principles. When I have a thin ridge, basically I can use a ridge plate, I can do a GBR, traditional GBR block, or use a tie mesh. When we're talking about the maxillary sinus, we can basically avoid and use short implants or tilted implants, or in more demanding cases, sometimes we go for the zygomatic implants, and sometimes cross the sinus, sometimes go outside the sinus, or we can graft the sinus. And the graft can be crestal or lateral. But today we are going to focus on the mandible. So what is the main problem that we have on the mandible? Everyone knows that the main problem that we have is the inferior alveolar nerve. It's a structure that we have that is in the middle of the space that we want to put the implants, right? So we have basically 3 options to deal with it. And of course, what you think it's the most easy one? The most easy one is to avoid it, of course. So how can I avoid? Short implants, tilted implants, reconstruction of the ridge when possible, not always possible, because as you know, in the posterior mandible, it's very difficult to grow in high because we have a very cortical bone, and implants between mental foramina, and we avoid the inferior alveolar nerve and the mental nerves. But we can also use other option, that is the trespass. And the trespass, we are talking about a different plan. We have the nerve and we have the implant on the front or on the back. When you see a 2-dimension X-ray, it looks like the implant is trespassing, is cutting the nerve, but it's not, because it's in a different plan. And the most demanding situation, that is to move the nerve. And this is not so extraordinary, and is a technique that is described for many years. And I'm personally doing this lateralization and transposition for about almost 10 years, and with very good results. Of course, it's a sensitive technique, but it's a very predictable one with a high success. And we have basically the lateralization and the transposition. And what is the difference between these 2 concepts? The lateralization, we only pull the nerve, okay, to put the implants and pull the nerve back. So we don't relocate the mental nerve, the mental foramina. In the transposition, we are going to cut the incisive part of the nerve. Of course, not the inferior alveolar nerve, not the mental nerve, but the incisive part goes to the incisive part of the shin. We are going to cut it 3 millimeters in front of the mental nerve, and we're going to move the mental nerve distally. I'm going to show this all with clinical cases, just to have an idea, just to start to imagine the solutions. Of course, we have also other simple solutions that's trying to avoid. And the short implants, nowadays, we know that they work very well. And we know that in the posterior mandible, the regeneration is very difficult. So we know by the literature, I have this article here, but there's so many that support this theory, that we have the same success rate when we try to reconstruct the ridge or we use short implants, because when we try to reconstruct the ridge and put normal size implants, the success rate is the same as using short implants. So to be honest, I prefer to use short implants to big regenerations because it's less complicated, it has less, it's less expensive, it's less everything, and sometimes less is more. Let's show a simple case, a trophic case, of course, that old lady, 82, diabetes, that has this very atrophic jaw, okay, and has the mental nerve on top of the graft. So the problem is the patient doesn't have any retention. That's one problem. And the second problem is when she's using the jaws, chewing or talking, she feels that she's pinching the nerve because the prosthesis is clicking, is doing some pressure on top of the nerve. So in this situation, of course, the first situation I thought, because it's a very atrophic mandible in the posterior zone, I thought it was not very logical to do any transposition or any lateralization because of the age. I said to the patient, okay, let's try to put some implants on the front zone and do overdenture. And the patient said, no, I don't want any overdenture. I want something that is fixed because I'm going to do implants. So I said, okay, it's not so easy case to do that, but let's try, because in the front between mental nerve, you have some good cortical bone, not medulla, but cortical bone. Let's try to put some short implants parallel and see if we can manage that, because on the upper we have traditional prosthesis, removable prosthesis. So in this case, we managed to do 4 implants for an ivory situation, metalloacrylic. I don't know if it's traditional in Syria, but in Portugal we use a lot this kind of rehabilitation that is not ceramic, it's acrylic, but with a metal frame. And we consider it as a definitive structure. And but one of the main things that we have to be careful in the surgery, we can't do a traditional incision on top of the graft, otherwise we're going to cut the nerve. So we have to go with the incision a little bit lingually to avoid the mental foramen that is really on top of the canal, as you can see on the arrows. And the option here was to use like short implants, in this case 7 and 8.5 on the cortical bone, do the incision to avoid touching the nerve. So here we are trying to avoid the nerve. The torque was very high because we had a very cortical bone, almost no medullary bone. And the ISQ, the implant stability quotient, that is the vibrational stability of the implant, also very high. And technically we have even the conditions to do immediate loading with these values. Nevertheless, we have a patient that is 82, that is diabetic, that is with a very atrophic jaw, so it's not very logical to do immediate loading. It's better to wait for 2 months. And in this case, I select healing abutments and I adapt the old prosthesis with a soft reliner on top. And after 2 months, I did the final rehabilitation with metalloacrylic structure. And this case has already more than 6 or 7 years follow-up, and the patient is working very, very well. Of course, I didn't extend too much the prosthesis posteriorly. If you can notice, I only have 1 premolar and 1 molar. But for this patient that is 82 and it has a traditional upper removable prosthesis, it works perfectly. So the patient is very happy with the rehabilitation. And of course, we have the concept of all-on-4. And all-on-4, when we started with Renmark, we had parallel implants, and then we started with linear clothing many years ago. Now it's becoming more normal. And then the all-on-4 concept with tilted implants a little bit later with Dr. Paulo Malo. And of course, this technique has advantages and disadvantages. I'm not going to focus on this, but just to understand that not always all-on-4 is indicated. It's an indication, because if you have like natural teeth from premolar to premolar, should I remove 8 teeth to put 4 implants? It's not logical at all. If I have a patient of, for instance, 30 years old, it's not logical at all. So the all-on-4 has its own indication, its own advantage, but it has also limitations and is not for all the cases. And of course, it has some advantage that we don't do a lot of regeneration. It's cost-effective, a little bit better. It reduces the number of implants. Of course, if you have natural teeth that are good to preserve, it's not logical at all to remove the teeth to do an all-on-4. But what's the idea of parallel versus tilted? I'm going to tell you what is in the literature, and that's what I'm using in the last 18 years that I'm working in implantology. When I have enough bone, posterior bone in height to put implants of normal size, when I'm saying normal size, I'm saying 10 or more, I prefer to put parallel. But if I have less than 10 millimeters, I prefer to go in front of the mental nerve and do angulation on 45 degrees. Because we know that tilted implants have less cantilever force on the distal part. But of course, we have to have long implants of at least 14 to do this technique, and diameter at least of 4. But of course, if I can go parallel distally and have a normal time, a normal implant size, I prefer that. If not, I prefer to go between mental and go angulated. And of course, also the deflection of the mandible when we open and close the mouth is less, it causes less stress when you go between mental foramen, because the bone is more vertical and you don't have the deflection of the mandible. Just to show, for instance, this is a typical all-on-4 with angulated implants. The nerves are relatively superficial, not so superficial like in the first case, but we go angulated. Sometimes we go, it depends, 25, 35 till 45 degrees, ideally. It depends on the brand and what are the abutments that you have to compensate this angulation. But this can be an option if you don't have teeth on the anterior zone. It's not logical to do a lateralization to put 2 parallel implants. You go, you angulate it, you do traditional prosthesis, eyebrow, acrylic, metal acrylic, and this case is already with 7 or 8 years of follow-up and is working quite well. But of course, we have indications for one or other things. So let's start a little bit focusing more now on the trespass and on the lateralization and transposition that are the most sensitive techniques. And let's talk about like basic considerations that are, I think it's important to remember, because probably all of you know this, but it's important to remember and to talk with the patient regarding this. So we know that we have obliquous traject from posterior to anterior. Okay, we cross. So we can't go doing a lateralization too much distally because the nerve goes lingually. So we prefer to go more on front. There are different techniques with very high success. I'm going to show the difference of techniques. But most important of all, this nerve is a sensitive nerve. It's not a motor nerve. So when the patient is very scared to do this kind of procedures and says, oh my God, because I'm going to not function with my lip or my, it's not true. So the things that can happen is a paresthesia or a hyposthesia or even a hyperesthesia, but normally it's a paresthesia that in all of my cases were temporary, but sometimes it takes a few months to recover. Normally it takes 2 months, sometimes even less with the right therapeutic, but it's a sensitive nerve. So the patient will not feel temporary and it will start to improve with time. So this is very important. And of course, we have several techniques. Sometimes we mobilize the mental nerve, sometimes we don't. Sometimes we cut incisive parts, sometimes we don't. So there's a lot of variation inside the technique. But basically, we can consider trespass, lateralization, and transposition, as I explained before. But what is the indication of this technique? Because each technique works well if it's applied in the right situation, with the right indication and with the right knowledge. So the indication by the literature is at least 8 millimeters of total posterior mandible height. I'm not telling on top of the canal. I'm talking about all the length of the mandible. And why do I need at least 8? Because of the risk of fracturing. If I'm opening a window laterally, imagine a sinus lift, but on the lower jaw, okay? That's just to have an idea. So we are going to open a window. In this case, normally it's a square window. If the mandible is very, very thin, about 8 millimeters, what can happen when you're trying to put the implants, you can fracture the mandible. So this is a risk. So that's why at least 8. And what is in the literature, it says severe atrophy of the mandible with less than 9 millimeters on top of the canal. To be honest, if I have 9 millimeters on top of the canal, I don't do lateralization or transposition. I try to put short implants because I have short implants. So try to simplify always. Only use the techniques when you don't have any other solution that is simple to use in that situation. So I only use this in situations that I have like 3 millimeters, 4 millimeters, situations that it's impossible to build like 10 in height. Okay, that we are talking about limit situation, and normally that situations are failed implants on the posterior zone. Okay, so I'm going to show this step by step. But one important consideration, we know that many years ago we didn't have piezo, so this technique was done with a traditional burr. In my time that I'm doing this for the last 10 years, thank God I have piezo. And why should I use piezo? And I think piezo is mandatory for this kind of surgery. As you know, piezo cuts the hard bone, but doesn't cut soft bone, doesn't cut the nerve, doesn't cut the tissue. So that's important because we need to open a window to localize the nerve. We want to retract the nerve. If we do a transposition, we will cut the incisive part of the nerve, okay? So piezo, I think for this kind of surgery is mandatory. More than any other surgery in the mouth, piezo surgery is mandatory. And when you do the transposition, the variation that we are telling that we are pushing the mental nerve distally, we have to cut the incisive part of the nerve. And where do I cut this incisive part? 3 millimeters mesial in front, okay, of the mental nerve. So we have to expose a little bit the incisive nerve to cut that part, to do the transposition. And then you will go back with the inferior nerve and the mental nerve. Of course, one of the situations that can arise from this surgery is a temporary paresthesia. But I have a specific protocol that I use for this protocol for at least 6 or 7 years that I'm using this protocol that works really, really well. And I use corticotherapy during the surgery and a few days after to avoid the swelling and compressing the nerve. That's one. PRF, plasma-rich fibrin. Why? To involve the nerve and stimulate the nerve to heal the schwann shells and the fascia around the nerve, because we are always stretching a little bit, even if you are very careful. The vitamin B complex, 1, 6, and 12. It's recommendable for ideally 2 months, but sometimes you only use it 15 days or 1 month if the paresthesia will revert totally. And the low-level laser therapy, LLT. And this low-level laser therapy, the red and infrared laser, are used as a biostimulation and as a potential of the healing. I'm going to show all the protocol a little bit in the front, but just to have an idea how I prevent dealing with some paresthesia more aggressive. So I always prevent before I start with the corticotherapy. I use the PRF. I start with vitamin B in the day of the surgery. So I use the low-level laser therapy the first time intraoperatory, and then I do in 2 or 3 days from 6 to 10 sessions. Normally, after 6 sessions, the patient is totally recovered. And of course, like any other technique, we have advantage and disadvantage. No technique is perfect. No technique is applicable in all the cases. But the lateralization transposition has some advantages. You can use long implants because you are using the whole length of the mandible. You go to the basal bone of the mandible. You can do bicortical anchorage that gives you a primary stability that is very, very good. One single surgical procedure, you can do the regeneration, the implant placement, everything at the same time, and the mobilization of the nerve. You are seeing the nerve while you're doing the implant placement. This is a big advantage, because sometimes when you work in the limits, sometimes you do mistakes of 1 millimeter, and it's enough to do a paresthesia, and you're not mobilizing the nerve. So here you are seeing the nerve. You can, retract the nerve, put the implants, and put the nerve back. And we have good biomechanical relation between the crown and implant flap. Disadvantage, of course, no technique is perfect. It's technical sensitive. There's some minor risk of mandibular fracture, as I told. What are the ways to minimize the risk of fracturing? Select the case properly, at least 8 millimeters of total height of the mandible. And also, there's some very specific indication. When you do the window to open the nerve, it has to be parallel to the basis of the mandible. If you do a window that is tilted regarding the basis of the mandible, normally is the point that distal point that is weaker, that it cracks. So try always to see, try always to imagine before on the CBCT, prepare yourself, have a good visibility on the surgery, and try always to use your basis of the mandible as a reference plan, okay? And one technique that I use that I think is very useful, I use a pencil, a sterilized pencil that I put in the autoclave, that I design my window to be easier for me and for my assistant to see where I need to cut and avoid like tilting when the patient moves, okay? It doesn't compensate the upper receptor of the crest. This we know, so sometimes we have to put some pink ceramics or to simulate some roots, and the risk of neural cells disturbed, normally the most common is paresthesia. So let's present the case. Let's start to present this cases step by step. And a case that I think is very interesting and very educative because it has a trespass, a transposition, and a short implant in the same case. We have two sides, third quadrant and fourth quadrant. In one quadrant, we have a trespass, and the other quadrant, we have a transposition and a short implant, okay? So let's start with this case. This case was a patient that lost implants prior. He had implants for around 15 years. He lost the implants. And then the patient wanted to do the things for yesterday, as all the patients want. But the problem is that we didn't have a lot of conditions to do the traditional implants. But I did a CBCT, I analyzed the situation, and I talked with the patient, and we now realize that in the third quadrant, probably we had to do a transposition on the 35-36 position, so second premolar and first molar, and on the 37, I managed to put a short implant. On the fourth quadrant, it looks like more or less the same, but we have a more width crest. So in this case, I try to do a trespass to avoid, I'm dealing in a different plan, okay? So I'm going to show step by step. So this is the initial status. The patient had class 3, he needed orthodontic surgery, but he didn't want. So we had to deal with this occlusion that is not the most favorable, but it is what we have. Sorry, let me go back here. This is important to see. So if you see in the CBCT, we have about 3 millimeters, 3.7, on the 35 and 36 position on top of the canal, okay? And we don't have a lot of width in a way that we can trespass. So in this way, the only solution here, I think, and the more logical one, will be to do a transposition. But on the green arrow, if you see on the 37, we have 9 millimeters. With 9 millimeters, I can put a short implant. Even I can put an 8.5 if I'm experienced. If I'm not experienced, I will go for a 7, okay? So my option was to put a short implant on the 37, and then to do the transposition on the 35 and 36. As you can see here, I'm using the pencil to design my window. This is already the nerve exposed. Sometimes I have to release a little bit the fascia around the nerve. The nerve is not only one nerve, it's several bundles between 5 to 8 with the vessels, with the lymphatics, and has some fascia around, and sometimes the fascia is very strong. Sometimes you have to release it a little bit to mobilize. And of course, with piezo, I'm doing my window, as you can see here. And then in this case, we remove the window entirely. This is autologous bone, so it's the best bone that we have. We don't throw this away. We are going to use this a little bit further. We can use it. Normally, we need to put it in a bone mill to reuse it, because it's almost impossible to re-put it again in place and stabilize, because we have already the implant, we have the nerve, and the risk of crashing the nerve is big. So it's preferable to use this in a bone mill, and then with PRF, for instance, I'm going to show, I always use the PRF also to mix with autologous bone, the IPRF, and to re-put, but in a different consistency, okay? You can see here the nerve, you can see well the inferior nerve, the mental nerve, and the incisive part. You can see a little bit of the incisive part, about 3 millimeters. And that is the place where I'm going to cut the incisive part of the nerve. So here you can see already the incisive part cutted, and I'm using a rubber to retract the nerve. Anyone knows what this rubber is? This is not, sometimes, some years ago, I was using some rubbers that are traditional for cardiac surgery, some strips, but they are quite expensive and not always easy to obtain, at least in private. So I'm using my glove, my sterilized glove. A sterilized glove, you cut the upper part and you use it to retract the nerve. It's push, but not too much, and it's sterilized already, so it's a way that is quite easy and affordable to use. So I'm using my glove to retract, and now I'm putting my implants with the nerve already outside the place. Okay, so I took the nerve outside in this case, because I'm doing a transposition, I'm putting the nerve on the buccal part, and I'm preparing the places for my implants. And you can see here, of course, normally in these cases that we have a good ridge and a good cortical bone, normally we have very good primary anchorage in torque and ISQ. Of course, if you have a very thin ridge, that's a different situation. And I'm going to show another case that we didn't have this kind of primary stability. But in this case, look at the stability. We have very good torque because we have bicortical anchorage. We have no wall on the buccal side, but we have the lingual wall, and we have the two corticals that are blocking my implant. So torque's around 55 or 50. And the ISQ, that is the implant stability quotient, the vibrational stability of the implant, that nowadays is considered more important than the torque to measure the primary stability, also very, very high. 83, 84, 82, I can tell you that more than 72, we can do immediate loading technically, okay? So very high stability. And we are using the PRF, in this case, APRF, to involve the nerve around to create a new fascia and to protect the nerve of staying in contact directly with implants that are a little bit aggressive. And in this case, I'm trying to convert my lateral wall that I removed because I can't put it like this in a hole. I'm going to use some piezo to cut it and then a bone mill. And I will use some IPRF to mix because it has also some growth factors from the patient, from the blood of the patient. And I'm going to do like we call a sticky bone. And it's a kind of a mix. And I'm going to put on place. As you can see here, it's in place. My nerve is already distally, okay, and then I put some APRF on top again to stimulate and to avoid contacting the bone with the periosteum. And here you can see immediately after surgery, look that the window has to be totally parallel to the lower part of the mandible. You can see that distally we have the short implant, and then on anterior we have the implants with bicortical anchorage. And then after healing, normally the stitches I use Supramid 4 zeros, and I normally remove it after 15 days. And this is the protocol I use for paresthesia to revert my paresthesia quicker. And this protocol is the first session is done intraoperatory, and then normally we do between 6 to 10 sessions, and between 2 to 2 days or 3 to 3 days. And we use the infrared laser and the red laser. The red laser is 660 nanometers, and it's just for stimulation of healing and for anti-inflammatory purposes. The infrared is more for biostimulation of the conduction of the Schwann cells and for the nerve, and it's a much higher doses and with much time per point. Okay, so the infrared 1 minute and a half per point, and the red 10 seconds per point. With these settings that in this laser already comes with the settings of the laser, but if you have a laser that you can have to put it by hand, you should have to put these numbers. So 167.5 joules centimeters by 70 milliwatts in the infrared, and 10 joule centimeters by 40 milliwatts in the red one. And this is the left side after doing the rehabilitation. Of course, we can't compensate the lack of high, so we have to put some pink ceramic. In this case, I had to use some angulated abutments to correct and to put as a screw retain. That is always better, that if you have some problem, you remove it, because the cemented is always more problematic and has more risks of periimplantitis. So it's always preferable to do it screw retained. And so the right side was not so different from the left side, but we had around 6 millimeters, 4.5 in some places, as you can see here in the CBCT, but we had a little bit more width. So in this case, to avoid the bilateral lateralization or transposition, I proposed to the patient, let's try to do a trespass. In this case, this trespass was free-handed. We didn't use any guide. This case has already about 6 to 7 years. If you ask me, isn't that more dangerous than doing the lateralization? In some situations, yes. If you're not knowing exactly where you're going, yes, it's more risk because you're not seeing the nerve. You're imagining that the nerve is there and is trying to trespass freehand. But in this case, I wanted to avoid to do bilateral lateralization. I have one case that I did bilateral, but normally I prefer to avoid bilateral. And so in this case, we managed to do a trespass. So in a trespass, we are not very concerned about the angulations of the implant. We know that we have to angulate the implant to not cut the nerve and to trespass the nerve. So in that sense, we are always counting that in the prosthetic part, we are going to use some angulated abutments to correct it. So here, I'm not concerned even with the parallelism. I'm concerned not touching the nerve, okay? Freehand, 3 implants. And then here you can see the torque was quite high, 60, ISQ also quite high, 80. And I put the healing abutments. You can see here I can use some orthogonal bone that I use from the burrs to put in some colors of the implants. And I'm putting healing abutments, Supramid 4 zeros. And here after the healing, I changed for angulated abutments and I did screw retained crowns with some pink ceramic. The patient is happy, doesn't show any of the pink ceramic. It can use the water pick underneath, so he's happy with it. And this case has already about 6 or 7 years. And you can see here, this was an X-ray that I did a few years after, I think 2 or 3 years after. And you can see, and I did a CBCT after the implant placement to see exactly, because the patient didn't have any paresthesia on the 4th quadrant. On the 3rd quadrant, in this case, it took 1.5 months to recover totally. And you can see here on the 3rd quadrant that you have bicortical anchorage, and you can see that the window is already with some new bone, but not very cortical. But after 2 years, almost the bone is almost completed, but not very cortical. And on the 4th quadrant, you can see that we are crossing the nerve. We are trespassing the nerve without touching the nerve. So in the 4th quadrant, trespass, and in the 3rd quadrant, transposition and a short implant in the distal side. So I think this case is very educative because it has 3 different techniques in the same case: short implants, transposition, and trespass. And it has already about 7 years of post-op, and the patient is quite well, and now is taking care of the hygiene and going to the controls often. And now let's show a thing a little bit different. That is the most uncommon thing to do, to be honest, because when I started to do these techniques, I always try to do lateralization. But we have to realize that if we push more than 5 millimeters the nerve, we will damage the nerve, even if we don't cut it. So nowadays, I use much more the transposition than the lateralization. So I prefer to cut the incisive part of the nerve and mobilize the nerve. And it's much easier to work. But in some cases, like this one that I'm going to show, the mandible is so thin, the vestibular wall is so thin that it's possible just to retract the nerve, to put the implants and then put the nerve back in place. In this case, of course, when we are talking about lateralizing the inferior alveolar nerve, in this case, because I wanted to work near the mental nerve, I had to lateralize also the incisive part of the nerve and the mental nerve. So I'm going to do a block lateralization, okay? let's show the case. So also a case that lost implants that were functioning for 15 years or so. We had about 4 millimeters on top of the canal, but worse than the 4 millimeters, we had very, very thin ridge. It was like an ampoullette, is doing like an S. Very young patients, 38 years old, and with teeth on the anterior. So what should I do here? The high of the mandible, if you notice, is not so resorbed. Is a little bit, but the nerve is quite up, and we only have about 4 millimeters on top, and it's very thin. So the solution here were not very. There were not very many options to deal with this. So I talked with the patient. I told her that I thought the lateralization could be a good option, and the patient accepted, and we did it. So this is the initial status of the patient. And here, as you can see, we have even nice variation on this patient, because we have main mental nerve and a small extra mental nerve, as you can see. If possible, try to don't cut and try to put it together. In this case, it was quite easy because they were really side by side, and we only had like a small tip of bone. But sometimes we have two nerves. I have some cases even that I was not doing lateralization or transposition, but I was doing regeneration, and we have two mental foramina. And sometimes even three, but two is more common. I'm removing a little bit the fascia that is around the nerve to permit a little bit more movement, because I need to pass my glove, my retractor of plastic, of rubber, to do the window around. And that is one of the most delicate parts of the surgery. As you can see here, we are now searching the canal and seeing where it goes. And I'm going a little bit more front to the incisive part of the nerve, and mental nerve, and then incisive nerve. Always I like to use my pencil to draw, and I'm using piezo, as I told. I think it's mandatory in this kind of surgery. And I'm using the glove to retract. As you can see here, I'm doing the window. I did a little bit on the front to the incisive part. Now I'm doing a little bit to the back. As you can see here, the nerve is quite superficial. In the other case, we had like at least 5 millimeters in front. Sorry. In this case, after removing the wall, you can see that the nerve is almost on the surface. So in this case, it was logical to try to do the lateralization and not the transposition. As you can see here, now I'm passing the glove and retracting the nerve with an instrument that is kind of a small instrument with a ball on the tip to go back to the nerve and do like a track of the nerve. You shouldn't push too much. This is very important, because if you push more than 5 millimeters or around this, the risk of paresthesia is higher probably than even cutting. So you shouldn't stretch too much. And here, I think this photo is very beautiful, but because you can see the trifurcation of the nerve, you can see the inferior alveolar nerve, the mental nerve, and the incisive part of the nerve. In this case, because it's a lateralization, a pure lateralization, we are not cutting anything. We are just stretching a little bit. We are going to put our implants and put it back again. You can see here this image. Now I'm using two rubbers from the glove, one from each side, one from the incisive nerve, another one from the inferior alveolar nerve, and the other one you can see is the mental nerve. And now I'm trying to put my implants. Sometimes the patient doesn't open well the mouth. Sometimes the bone is too thin, like this case. So many times we have small cracks, but because we have bicortical anchorage, normally we have at least good primary stability, not like the other cases that I showed, but this case will be, of course, less primary stability because it's a lady and it has a very thin bone and it's not very large, it's not very width. And I'm putting the implants. As you can see here, the torque here was not so high because we have this very thin ridge, namely on the 36th position. And it was around 25, but the ISQ was 60, is not so bad for this situation. And we are using the PRF as membranes to involve the nerve. And then also, as I told, we can use the bone of the wall on the lateral part normally after using a bone mill. And I'm using the first session of the laser therapy intraoperatory because we are seeing exactly where is the nerve. And you do all the trajectory. Normally you start lingually on the Spix point of the entrance of the nerve distally, and then you go lingually, and then you cross vestibular to the mental foramina, and then you go to the lip. So you'll do all the cross, all the correct length of the nerve. Sorry. I plus one. Okay, sorry, my pointer is with lights. Here you can see supramid for zeros after 15 days, after a few months, and then in this case, of course, I put the copper screw because I think it was logical because it was a more demanding case. And then the second section normally only after 6 months, and then the final restoration after 7 months, around 7 months to 8 months of the initial surgery. Screw retained, as you can see here, with pink ceramics, but no problem for the patient. Screw retained if you have to remove it by cortical anchorage. And here, this case has already 6 years of follow-up. And the patient is happy, but it was the case that took me more time to recover because I think it was because it was a lateralization and we didn't cut, so it stretched a little bit and it took a few months to recover. It was the case that it took longer to recover. That's why nowadays I do more transpositions than lateralizations. Now let's show another case that is also a good case because has an old implant that we are doing the explantation in the day that we are doing the transposition. And it's also a funny case because it's a case of a patient from Italy that came with a colleague, Dr. Pierluigi Casella, that sent that patient to me to Portugal. So he sent me the status, he sent me the X-ray CVCT, and when she arrived to my place in Portugal, she already had lost the distal implant. It was a brain mark with 20 or 25 years or something. And the one from the 44 position, it was with some loss, but it was not mobile. But we thought it was not logical to maintain that implant, so we did explantation of the 4-4, the old implant, and we managed to do a transposition and of the inferior alveolar nerve. This patient is very healthy, non-smoker, very keen to the hygiene, very, very careful with all the steps of the surgery. And the provisionalization and the final restoration was done then in Italy. So I did the surgery in Portugal. She stayed only for 3 days. I did only 2 laser sessions, and then Dr. Pierluigi did the rest of the sessions in Italy. And in this case, she recovered after 15 days. She was really, really a fast recovery of the paresthesia. And then Dr. Pierluigi did all the provisionals and some free gingival graft. And here is the initial status, okay? So that implant that was showing the metal, as you can see, after raising the flap, we are going to remove it. Sorry, it's not passing, okay. Here, so that one, we thought it was not logical to maintain. So we treat it with explant it, and we are using here some low-level laser therapy, but with antimicrobial photodynamic therapy. This blue dye is a dye that stains bacteria, and then it stays for 1 minute, then you rinse with saline, and then you apply a red laser that will kill bacteria. This is just to be sure that the place that we had the explanted implant was not contaminated with bacteria and will damage my new implant. So when I do post-extractional or when I have pathology, when I do explantation, I prefer always to use the low-level laser therapy as an extra guarantee of success of my surgery. This is called Elbow Blue. It's from Bredent, but I think other brands also have it. And here you are, of course, identifying the nerve, trying to pull it gently, and doing our wall to find our incisive part and inferior alveolar nerve part. As you can see here, it's more easy to start with the anterior part because even if you do a lateralization, you always need to normally move a little bit the incisive part. Otherwise, you can't pull to put the implants. And if it's a big mandible, it's almost impossible. Of course, there's described in the literature several variations of the techniques. I'm showing what I normally use and what I think is easier to use. And then you go for the distal part with piezo or with the piezo. And normally what I do, I cut the cortical bone, and then I use a chisel gently. Normally I don't need the hammer, just the chisel to do like this. And when it starts to move normally, it goes out the window. And you can see there the incisive part of the nerve. And here you can see the medullary part. You have to remove all the medullary when the mandible is very thick. After removing the cortical bone, you don't see the nerve right away. You see medullary, and then you have to remove the medullary to discover the nerve. When it's too thin, sometimes when you remove it, you see the nerve right away. And then you have to remove the medullary and try to remove the nerve inside the canal, inside the medullary. And in this case, I managed to maintain part of the mental foramina, the bone part, and to block it distally. Not always is possible. Sometimes I remove it totally. Sometimes when I manage, I prefer to maintain because it maintains my future mental foramina distally. So in this case, I could slide it through the nerve and block it distally, as you can see. And here I'm putting the implants, in this case, really by cortical anchorage, implants of 16, I think. Yes, 4 by 16. And I did the implant that we explant a little bit more lingually because it was a little bit buccal. And you can see there the incisive part that was cut and the inferior nerve and the mental nerve that was mobilized. And I'm using, of course, the ISQ to measure the implant stability, and I'm using the PRF for biostimulation and to protect my nerve around and to avoid some irritation from the implants. As with APRF membranes or plugs, sometimes I use plugs, but in this case I use membranes. You can see here. And then I'm using the particular bone from the wall. I use piezo to cut it a little bit, and then I use the bone meal, and then I mix with IPRF, and I put it in the places that I think it's more necessary. And this is the patient immediately after surgery, in this case, really by cortical anchorage. And what we are mapping there in that photo of the lip of the patient is the paresthesia after 3 days. So in this case, the paresthesia was really, really small. Normally, in cases that we have big paresthesia, we have all the block, all the chin, lip, till the middle zone. And then because we have the incisive part of the nerve from the other side and the stimulation from this side, it starts to reduce. But in this case, after 3 days, she was like this. And I did the second surgery. And then the colleague had a different laser, but with the same, more or less the same function that we had in Portugal. And he did the laser in Italy. And after 15 days, she was totally recovered. So this was a very good case in terms of recovery of the paresthesia. And it was a transposition, not a lateralization. And here is the session, the laser session that we do intraoperatory. We start lingually on the entrance of the inferior alveolar nerve, then you pass through the ramus, and then we go laterally, and then we go to the lip with the same protocol that I showed before, and cortical therapy, PRF, and vitamin B complex. And this was the temporary prosthesis that Dr. Pierluigi did in Italy. With the BOHPP abutments that are kind of cushion abutments that are shock absorber, and with acrylic. But this was done only about 3 months after the surgery. Because in this surgery, even if you put provisionals, you should wait a little bit because you have to have some consolidation of the mandible. These abutments are also from Bredent and are from BOHPP. Then we saw that the gum in vestibular was not perfect, okay, because we had not very good keratinized tissue. It was not with infection, was not with inflammation, but the patient was very, very demanding. So we said to the patient, maybe it's better to do a free gingival graft. This was apparatus that we call T-scan. I don't know if you have it in Syria. It's a digital occlusion assessment that we used to see before doing the occlusion assessments of the provisional and after. And you can see that after doing the occlusion assessment, we have a more centered and more equilibrated occlusion, as you can see here. So this was a teamwork between me as an oral surgeon, my assistants that are very well trained to do this kind of surgery, and Dr. Pierluigi Catel, that is a prosthodontics, but also does surgery. He helped me in the surgery in Portugal, and then he did the rehabilitation in Italy. As you can see here, because we weren't happy with the soft tissue, Dr. Pierluigi performed a free gingival graft with vestibuloplasty on the vestibular side, and we gained a little bit better profile and more thick profile. And this is the final rehabilitation that was done by him after about 9 months to 10 months after the surgery. And then after 2 years, we were curious, and so we performed a CBCT. And we to see exactly where the place of the implants, how was the healing, if we can see the new foramina. And as you can see here in this CBCT of 2 years post-op, you can see here the new foramina that is very well identified, and everything was really good, well healed. So let's jump to conclusions. I don't know if I passed time, but just let's, because I like to talk and then I feel enthusiastic, but let's jump to
take your time, Professor. It's a great topic and we are really interested in what you are describing. Take your time.
So I'm going just to do the conclusions. So as a general conclusions and some specific ones too, we know that in these situations, we can use the short implant with high success. And when I have conditions to use short implants, I prefer to use short implants. The All-on-4 technique are really a great tool, but only in the cases that we want to avoid the nerve, but we are not going to extract teeth that are good and are healthy just to do All-on-4 in a 30-year-old person. So it has its own indication. The inferior alveolar nerve lateralization and transposition has very specific indications. I only do this when I have very short amount of bone on top or very thin, normally 3-4 millimeters or less, or sometimes I don't have nothing. The nerves are on top. and have a high rate success. The neurosensorial effects are normally temporary and reversible, and normally the paresthesia is the most common. And I use vitamin B, low-level laser therapy, corticotherapy, and PRF to help reverting the paresthesia. And we know that the regeneration in the posterior mandible, in a place that is very cortical, is quite demanding and not always possible to grow in a lot of amount. So, and then as a general conclusion, I think we should believe that it's possible to share the stage with our role models. I'm an example of that. I studied a lot. I battled a lot to be where I am today, but I'm honored to say that I share the stage with some of my role models, some people that motivated me in the beginning of my career, and that I thought were God for me, and now I'm sharing the stage with them. So believe it's possible, but of course you have the courage to be a little bit bold and to risk a little bit much every day. Because if you start, you can be exceptional in what you do, but if you only do ordinary things, nothing will happen. So if you want to go a little bit further, try to raise your bar a little bit. Of course, be conscious and have your training, have your education. And I know I'm talking to a very specific audience that is very well trained and very well educated. But after you have your education, don't stay in your comfort zone. Try to go a little bit further. This is me crazy jumping over a plane. Of course, I was afraid when I was jumping, but then the magic happens when the parachute opens. So try to go a little bit further. So believe in you, be proud of you. Yes, you can, like I can. This is, if someone is interested in following my work, I have a Facebook group called Follow the Red that is free. Anyone can join. We have thousands of people there already. And I share my work, other people's works, articles, online webinars. So if anyone is interested, can go to the group and ask to enter, and then I will accept. And there is here also my contacts on LinkedIn, on Instagram. I have Facebook personal, but normally it's blocked because it's full of friends. So I think it's easier to go to the group, to the Facebook group that doesn't have limit of persons. And my personal email, if anyone has some question or needs some opinion or something. And I'm very glad. I hope that I was clear in my presentation. And if you have some questions, I'm here to try to respond. I think I can stop sharing. Okay, yeah. Like this.
Yeah, thank you a lot, Dr. Raquel. It was really an informative lecture. I really thank you a lot. I mentioned from the last or close to last slide you put, the last photo, you really interest in adventure. Even in the skydiving, you are doing the same in oral surgery. You hit the point, really. I really appreciate what you are doing. It was something unbelievable to deal with the ID nerve easily as you do. But I have some questions from the audience. Before I start the questions, we shared the lecture even on your group, Follow the Red. It is a great group. My friends here and colleagues mentioned that you are one of the greatest surgeons around the world. Okay. We're very happy that you are here with us.
I'm so honored with that.
You are dealing with some things that I haven't seen in even when I was in the States before. The first question is about Ostel. You mentioned that you are using the Ostel to measure the stability. I did a research last year. I noticed that the stability which we can measure by ratchet is not accurately reflected in the ICQ or Ostel, because ICQ Ostel give a range in the green area. Mm-hmm. Doesn't give us a number that it reflects what we feel that the primary stability, for example, for the immediate loading. I mean, what's your opinion about that?
I love Ostel, okay? Yesterday, no, the day before yesterday, I was lecturing at the 12th online symposium of Ostel with Professor Daniel Boozer, Scott Gans, and some big names internationally. It was my first time lecturing for them. I'm using Ostel for about 10 years. I started when I was starting to do research for my PhD. And at the beginning, to be honest, I was using more as a research tool. Nowadays, I can't work without it. It's something that I really use in a daily basis. And nowadays, and in the symposium, we were discussing this too, that, for instance, Professor Daniel Boozer, that everyone knows, he doesn't even look at the torque. For him, it's not important. To be honest, I look at the torque, but I look at the ISQ, and for me, ISQ is starting to be more important than the torque, okay? But he doesn't look. For him, he only sees the ISQ. Of course, he sees a lot of other things that we have to consider, the medical status of the patient, the complexity of the case, etc., etc. The bone density, there's a lot of criteria. We can see like this. But I think Ostel is a very good tool because not only you can measure it intraoperatorily, you can do the follow-up of the implant. I think this is the most important thing, more than having a number.
Because the rat gives us ideas about the immediate placement, but after that, when we are following up, we know nothing. We're just doing X-ray. We know nothing.
And sometimes the X-ray looks beautiful and it's not integrated, or we are thinking that it's perfect and it's not. So the ISQ, we have like guidelines that are not my guidelines. I can say to you that what I use for the brands of implants that I'm using to do immediate loading in a single implant, ideally I have torque 45 or more. Okay, 40. It will be.
Yeah, it's approved by.
And ISQ more than 72.
Yeah, that's right.
ISQ more than 72. If I don't have these two conditions, normally I don't risk. Okay. If it's multiple, we can downgrade a little bit the values because they are splinted, of course. So normally 35, 40 torque and ISQ of 70. If I don't have these conditions, I normally don't risk. Of course, I have already 18 years of experience, but for someone that is starting, it's better to have a guideline and try to, use the guidelines. But more than taking the decision of immediate loading, early loading, delayed loading, that is important. And we have like a guideline of 70, for instance. Less than 70, forget. Don't put the load on the implants. Even ideally, Professor Boozer was showing cases that after 4 months, he didn't have 70, he waits. Only when he has 70 or more, he puts on load. He's a very conservative, okay?
Because they are doing a compensation or accustomation between the Ostel and the measurements and the loading. And I think that sounds good because we are here as a physician. We are testing the implant. It's good.
Exactly.
We go for loading. The other question is, why don't you prefer to use magnification during like this accurate surgery?
It's a great question. To be honest, I only have one loops of magnification. I think when I went to UPenn, so I think 2 years ago.
Yeah.
But I never used it.
Because you are accustomed.
I'm going to explain why.
You are accustomed
to explain why.
Because I noticed that the incision by Bezo surgery very accurate, very line. There is no disturbance. Something.
I'm not against. Okay.
Yeah.
For me, I use glasses. And I use strong light, surgical light and strong light.
Yeah.
And I try to sometimes very, so 1-2 times a year, I use magnification, but I only have the small magnification, that is 1.5, okay? I don't like magnification. I think I lose the big picture.
Yeah, sometimes the magnification complicate the area and make a small disturbance to control that you are.
For me, in this kind of surgery, it's a delicate surgery, yes, but you have to see the big picture. You have to control the implant placement, retraction. If you are pulling too much, you have to control you and the people that are working with you. So I think when I put magnification, I'm so focused in one point that I lose a little bit.
You are going against the basics of the surgery. That means as wide as you see, as better as you do. But what about the
but of course, I know that a lot of people are working with magnification and don't know how to work without magnification. I prefer to work without magnification. Punctually, I put magnification, but not as a whole procedure, because I think I lose the I don't know, the big picture, the overall situation. I'm being the most honest I can.
The case that before the last one, you used a stain. Could you please a brief description about that? A stain, something blue stain. I didn't get.
Okay. So that it was we call antimicrobial photodynamic therapy, APT. And this uses a dye that is a blue dye that is phenyltoluene, I think, the principle, the chemical principle. But it comes with a laser.
Then the laser.
It's a laser, a soft laser, a low-level laser therapy, Graft. But instead of being the ones that I use in the paresthesia, it's one that has a very thin tip.
And the laser is transmitted by this
exactly.
stain.
The stain will color the bacteria, and then we rinse the saline for 1 minute to stain, 1 minute to rinse, and 1 minute to activate with a soft laser. And when you activate the laser, it goes with a chemical reaction that bursts the wall of the bacteria. It's an oxyreduction.
That's right.
It's very, very interesting. And it also kills virus and bacteria and fungus. So you can use it in Candida, in herpes.
This biofilm staying around the implant, you will control the spread.
Even for peri-implantitis, I'm using as a protocol now. Before I go surgically, I always try the non-invasive techniques, and I always try to do some sessions of laser therapy. And normally, with 1 or 2 sessions, it normally stabilizes. Of course, we are not going to gain the bone that we lost, but if it's a small amount of bone loss, and if you can control the sealing of the implant and the hygiene, or modify the profile of the crown, or modify the soft tissue or whatever, and if you can stabilize, normally you don't even need to do the regeneration if it's a small amount. So I'm using this laser as a protocol in post-extractional, in explantations, when I put implants immediately, in peri-implantitis, and all the lesions with herpes.
Do you prefer to supplement the medication with corticosteroids as you are making surgery?
I normally do. In this kind of surgery, I always do corticotherapy, even in difficult wisdom tooth, and I prefer, because I think it's much more comfortable for the patient. Okay, people say, okay, but corticoid blocks the inflammatory process, the regeneration. We are talking about 5 days, or is not, and the comfort of the patient is it's much better. And in this case, I think it's even more important to use the corticoid, because we don't want any compression. And with the edema,
and there is an edema, and we need to stop it.
Exactly.
What about the dilemma? What about the dilemma of B complex or nervion? Sometimes some researchers say it's not effective, but I know that all the physicians prescribe Norbion as a supplement to rebuild and
to reconnect.
Any reconnection of the nerve.
To be honest, I don't have any study comparing using or not using. By protocol I use, and it works. I don't know if I removed the complex B.
Because we are doing the best. We are doing the best to support the patient to get the best result.
Exactly. But I think it doesn't harm. So it's proven in some studies that it helps. In some studies say it doesn't do anything. But maybe even if it's a placebo effect, it's a tonic of the nerves, something like that.
The last question, when do you prefer to make a connective tissue For example, in connective tissue graft or free graft, for such cases in the posterior atrophic, after how long time could we make a grafting and regrafting of the connective tissue to rebuild a little bit of the papilla, like in your case? You prefer immediately or after how long time you prefer or advise?
So there are people that do it before. Okay,
Yeah.
they try to construct at least the more rigid tissue. To be honest, I think it's better after, because when you manipulate, you know.
You know where we need to build the papilla again. That's right.
So I think it's much better. So you do the surgery, you use the provisionals to try to put ovoid contour, and then many times in the posterior mandible you don't have keratinized tissue on the vestibular part. So normally after a few months, at least 3 to 4 months to stabilize. And then we do our free gingival graft, sometimes some vestibuloplasty, it depends. And sometimes we even manipulate a little bit with after we have the maturation with provisionals. Sometimes we even rotate a little bit the filler, but it's normally when it's stable, we don't, because here in terms of aesthetic, we don't need a lot of aesthetic. We need function, and we need to be sealed.
Oral health. Yeah.
And to be cleanable. So if you have some stable tissue, we are not manipulating. Okay, if we are talking about anterior zone, or sometimes we are like manipulating, but here we are more interested in having a healthy tissue that seals the implant, because even if you don't have bone, if you have a sealed tissue, you'll have an implant for life.
Yeah, Dr. Raquel, it was really a controversy issue that you are discussing. It's a great topic, and I really thank you that you accepted to go for such topic and lecturing in our university here. I hope that if you give us a promise that maybe the next month you can give us another appointment for Khoury technique. You sent me an email about the topics. I felt like something delicious is putting in the email, so I start to think topics. I hope you accept our invitation again for another lecture.
I know this topic is a little bit, I mean, some countries I know that they don't perform this in a daily basis. And now, for instance, in the United States, I know they normally don't do this kind of procedure. In countries that they have the issue problems of lawyers, and of course, first you have to be well prepared to do it, but it's not such a difficult procedure. You have to be instructed and then perform, and with time you start to improve your technique, and to be careful, of course. But I think it's a genuine option for some cases, and some cases that I normally will not solve with any other technique. I use this one. Of course, I prefer to use other ones instead of using this, but sometimes it's not possible.
Yeah, but the group of cases you mentioned, the group of surgeries, it was incredible and fantastic. Really, it was a great job. I hope you accept our invitation again in the next month to do with us a webinar about Khoury technique. If you have that time, I will.
I have some cases, but I'm not such expert in Khoury technique, but I have other topics that I feel, even we are talking about ISQ, I think it's also very, I don't know if you're using the ISQ.
No, we're using it. On behalf of the Dean of the Faculty of Dental Medicine, Professor Osama Jaban, we are really appreciate and thankful and honored for your lecture. Thank you a lot, Dr. Raquel, and I'm looking forward in the future, in the next either 1 or 2 months, to have another appointment with you and another discussion. I promise that the head of the Department of Oral Surgery will be with us. Really, thank you a lot. Great appreciation. Thank you, my dear. It was a fantastic thing to discuss. Thank you a lot.
Thank you. Bye-bye.
Bye-bye.